Hello there, my name is Declan Costello. I am an ENT surgeon in the UK. I'm a laryngologist and I'm president of the British Laryngological Association. It's a great honour to have been invited to speak on this all-day amazing marathon set up by the UEP, and particular congratulations to Haldun for setting it all up. I'm going to share my screen because I have a few slides just to go through with you. I hope those are coming across okay. So I'm going to talk about professional singers and voice surgery. I've been asked to speak for a maximum of 15 minutes, so I'll be as quick as I can. I guess the first thing to say about professional singers and voice surgery is that we don't very often have to operate on singers, but we'll come to that in just a moment. Before I kick off properly, I just want to share a couple of things with you. If you'd like to get your phone out, you can point your camera at the QR code here. I'd like to invite you to Cutting Edge Laryngology, which is the British Laryngological Association's flagship meeting in October in London. Promises to be an amazing programme set up by Chad Aliadji. Also, on the subject of the BLA and the UEP, please do come to Zagreb to join us in May. Again, you can point your phone at this QR code and that will take you to the link so that you can register and join us in Zagreb. So what are the main areas we need to think about when we're talking about surgery in singers? Well, there are a number of different things to go through. There's the psychology of performing an operation, which in and of itself for a singer is a huge thing to consider. They will need a lot of support, often from a group around them of speech and language therapists, singing teachers, sometimes psychologists as well. The timing and the actual decision as to whether and how and when to go ahead with an operation is absolutely critical. A lot of singers will just want to get on with things very quickly, but sometimes just rushing into an operation rapidly is not the right thing to do. Clearly, there are the technical aspects of the surgery, which will depend very much on what it is you're planning to do. And critically, for the long term and in terms of healing, we need to think about the recuperation and the healing time, the recovery period. So it goes without saying that the decision as to whether you're going to operate on somebody depends on the evaluation that you've made in the first place. Accurate diagnosis is critical. Stroboscopy gives us the best possible evaluation of the mucosal surfaces of the vocal folds. And increasingly, we're using flexible endoscopy with stroboscopy with chip-tip endoscopes to give us the best view. And for me, I think the dynamic information you get with a flexible endoscope, as opposed to the previous 70-degree rigid endoscopy, I think the flexible endoscopy is absolutely fantastic. The image quality perhaps marginally less, but actually the high definition chip-tip scopes are really giving us superb images these days. So and the information you get about muscle tension patterns and the posture of the larynx, I think, is really helpful. So I'm now almost exclusively using chip-tip flexible endoscopy for my stroboscopic evaluations. There are certain situations where you would not operate. Clearly a decision to have an operation on the vocal cords in a singer is quite a big one to consider. And there are very often situations where a singer can manage around a lesion, tiny little blemishes on the vocal folds. If they're not causing significant problems with the voice, the singer might say to themselves, I'd be perfectly happy to leave this as it is, and I really don't want to have an operation, and the incumbent potential risks of that. Has the patient had adequate medical therapy? I'll talk about this again in just a moment. There's a particular example I will show you of a patient who needed medical therapy before having an operation. I just want to show you an example initially of a patient who at this point in time definitely does not need an operation, okay? So this is a patient obviously with a right vocal fold hemorrhage. In this initial stage, surgery is obviously not required, not mandated. It may be that this patient is going to need surgery down the line. When this hemorrhage has resolved, it may very well be that they're going to need to have an operation to ablate any prominent blood vessels that are sitting on the vocal fold. But you clearly don't know that until some weeks down the line. And managing vocal fold hemorrhage is not particularly straightforward. it has, in my practice, I tend to get the patient to rest their voice completely for a couple of weeks and then monitor them serially with endoscopy in the clinic. And then if it turns out that there is a prominent vessel that has ruptured, and if that has, particularly if that's happened a number of times in the past, then you might be talking about surgery to ablate any prominent vessel. So just as an example of where surgery at this moment is not required, I think this is quite a good one. It's worth remembering also that the decision to operate is not an obvious one. And remember that the same laryngeal appearances can be treated in a number of different ways. What kind of laser you're going to use, if you are going to use a laser, whether you're going to use steel instruments or CO2 laser, for example, for excision. You need to be clear that you have the correct equipment and expertise, and it's not uncommon, certainly amongst laryngologists in the UK, for us to discuss cases with each other and to refer patients to each other if we feel that somebody else has got better skills to deal with it. We as surgeons, I think, need to be aware of our own limitations and how much we can get things better. As tempting as it is to paint an optimistic picture to the patients, I think it's incumbent on us to be realistic. Can we improve scar? Well, maybe, but not as much as we might imagine we might. So we do need to have the insight into our own abilities and ask for help. It's quite often the case that medical management is required before opting for surgery, and I'll show you an example of that in a minute. The surgery clearly is going to have to be scheduled around the patient's diary. And as keen as patients might be to just get on with things and do it quickly, it is often better to wait a little while, even several weeks or months, so that a patient has a hiatus, a lull in their diary, so that you can actually get the operation done at a better time. Again, surgical approaches will vary according to the lesion, vary according to the availability of equipment, vary according to the expertise and the experience of the surgeon involved. And we'll talk about post-operative management in a minute. We do have to manage patients' expectations. They are going to be nervous, but I think it's important that we emphasize to patients that perfection is sometimes not achievable. It depends on the lesion, and sometimes we can get patients precisely back to where they started from, but patients need to have an awareness of the limitations and the potential risks of surgery. So this is an example of a patient who very clearly does need surgery. This is a tenor who has had problems with his voice for some time, and he's got this, actually, this lesion, I think you'll agree, looks rather irregular and unpleasant. It turned out to be a benign polyp, but it was an enormous thing arising from the front of the left vocal fold. So just an example there of somebody who very clearly does need an operation. You saw an example a moment ago, somebody who didn't need an operation, at least not for the time being. This is obviously not going to resolve of its own accord. And then there's another scenario where a patient presents with a larynx and you're not 100% sure what the appearances represent. There might be a bit of swelling, there might be some prominent vasculature, and you need some time for those changes to settle down before deciding whether they're going to need an operation. Now, in this lady, there are a few things to say. There are a few tiny little telangiectatic vessels dotted around the place. There's maybe just a little bit of edema on the right vocal fold, a little bit of edema on the left vocal fold. But for me, I don't think the decision as to what to do was particularly clear. She was having problems with her singing upper registers. She was a professional singer singing in choirs in London. And it wasn't altogether sure what the underlying problem was. And this is a still photograph of her larynx. So as I say, a few small prominent blood vessels. There's that area on the right vocal fold, right mid vocal fold, which I think is worth just keeping an eye on. And on the left side, you get the impression of a sort of diffuse edema, but really nothing terribly clear. So she stepped back from her singing role. She had some medical therapy. She had some reflux treatment. And actually, a few weeks later, this was the appearance. So it became much clearer that, in fact, there was this tiny polypoid swelling in the middle of the right vocal fold. On the left side, you see contact edema as a result of the contact forces from the right vocal fold. And under general anaesthetic, that's what it looked like. So excising that tiny little hemorrhagic bleb in the middle of the right vocal fold was clearly the right thing to do. But we wouldn't have known that based on the initial appearances. So sometimes it's necessary to just sit back, treat conservatively for a while and then go from there. I won't show an example of this, but there are times when therapy, a reasonably prolonged block of therapy is required before providing any surgical options. And the obvious example of this would be vocal fold nodules. I operate on vocal fold nodules, bilateral nodules, very, very rarely. And it is only ever after a patient has had a comprehensive block of voice therapy. So nodules are almost exclusively treated with voice therapy rather than surgery. That's a relatively quick whip around surgery in singers, and I'm sorry I haven't got longer, but it would be nice to chat to you at length if possible in future. I hope I've outlined the fact that surgery requires careful patient selection, meticulous operative technique. I haven't really talked very much about operative technique, but clearly you need to respect the superficial lamina propria. Any lesion that you excise needs to excise the minimal possible mucosa, and micro flaps and using those sorts of techniques to drape over any residual epithelium, I think, is really helpful. The timing is absolutely critical. I would say for singers that they need a minimum of 6 weeks to get back to performing. And in that time, they're going to be gradually building up using their voice. My ethos around voice rest after surgery in singers and non-singers really is that they would rest their voice for 2 days, just 2 days, and then I give them a program of building up their voice over the course of the subsequent couple of weeks. And the evidence tells us that the epithelium has reformed by a week. And protracted voice rest, I know there are some practitioners who advise 2 weeks of voice rest and so on. I absolutely do not subscribe to that. I think it's important, in fact, that once the epithelium has healed over initially, that the subepithelial layer, the superficial lamina propria, is actually manipulated a little bit so that the collagen is laying down in an organized fashion. So relative voice use after the period of absolute voice rest. For benign small lesions of the type that we've seen here, I would suggest that 6 weeks or so of vocal recuperation before returning to performing is reasonable. I generally don't give PPIs or steroids or antibiotics after laryngeal surgery, but that is an option potentially. And there are times when actually a diagnostic microlaryngoscopy can be very helpful. In other words, if you're not clear what's going on in clinic, if the stroboscopic images are not giving you all the answers, then actually giving the patient a general anaesthetic and palpating the vocal folds carefully can be extremely helpful. I will stop there and I will thank you for your attention. I do hope very much to see you in Zagreb in May, and then hopefully in London for the British Laryngological Association conference in October. Thank you very much.